Hello, hello, my friends. My name is Jill Osborne. It is Sunday, October 15th, and it is time for another live IC support group meeting. Now, my purpose in doing these meetings is to make you strong, knowledgeable, informed. I want you to be able to walk into your doctor's office confidently with your head held high. You have done nothing wrong, no shame, no blame. Am I right? I hope so. I got to check a setting here real quick. Yes, I have audio. Excellent. Excellent. Now we're going to have some fun. We're going to have some fun in this meeting because I've been busy. We have some pretty amazing things that have happened in the last couple of days. So normally when I do these meetings, I do a little 30-minute intro and then take your questions. I have a lot to talk about right now. Late last week, I was asked by a friend if I would, uh, with 24 hours notice, create a presentation for doctors treating pelvic pain on behalf of patients. And what do we patients want to see? And how do we want to be treated at doctors' offices? So I got that invitation on Friday, worked all day yesterday, and gave it this morning at 6 in the morning. I'm going to give you that same presentation because I think it's important that you hear what we're trying to say, how we want doctors to treat us, all that sort of stuff. It's a very, very, very important. Hi, Sandra. Thank you so much for the 99 stars. And at the meeting, I found something that I hadn't seen before that we're going to do as a group because it's going to help us understand for those of us who struggle with sensitivity, it's going to help us rate it and help us make the case for treatment. So I got a really cool we're going to look at it kind of like a game, um, etc. And listen, you probably figured out by now that I absolutely love to decorate. I love Halloween, so you get to see one of my favorite witches, and I love my pumpkins. I have more. I purposely live in a very happy home, and I decorate it and I play with it all the time because I just want to be happy. I don't want to have a smile on my face. Okay, so and of course my phone is ringing and I'm not going to answer that phone. So, let's talk first about the presentation. So, imagine being the first speaker in a year-long series of courses for doctors interested in treating IC and pelvic pain. What an opportunity that was given for me. And I'm going to do that presentation for you right now. And for those of you on Facebook, you're actually going to see my slideshow. For those of you on YouTube, because we're simulcasting live on Facebook and YouTube. So if I'm looking here, I'm looking at Facebook. If I'm looking here, I'm looking at YouTube. For those of you on YouTube, it's already recorded. It will be uploaded and you will be able to watch it, but you're certainly going to be able to hear it. So let me go ahead and set this up so that you can, and I want you to think about what would you say to a young doctor coming into this? What would you want them to know? Oh, and actually, you know what? Before I do that, something else really big happened yesterday. And unfortunately, I can't really tell you about it yet because because it hasn't been released formally to the press. But something very, 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 very big is happening. I can't tell you more, but this is what I need. Are there do any of you know, hi Paula, any patient who is suffering from eye damage from Elmeron? Or did you? If you know anybody, would you please email me, icnetwork@mac.com. I have one of the biggest national magazines that is doing a story, but they want to put a face to this tragedy. And so, for anybody out there, if you've suffered eye disease from Elmeron and you're willing to share your story, we need you right now. We need to put some faces on this story. Okay. So my email address, icnetwork@mac.com, icnetwork@mac.com. Please email me so that I can get you connected with the writers. And the only clue I'm going to give you, I can't give you any clues. I'm sorry. I will just tell you it's the best of the best of the best award-winning journalists. Okay. So this is really serious. This is really promising. This is really encouraging. Okay, let's get back to this presentation. So hold on one sec. Okay, we don't need that. I do need my desktop. All right, so you guys on Facebook, you can now see my desktop. Right, there you go. And look, it's clean. I couldn't have a dirty desktop knowing that all these doctors from around the world were going to see it. So I cleaned it all last night. Okay, let's go ahead and do this presentation, shall we? Now, I think y'all can relate to this. When that next stop is 20 minutes away, but you have IC and you gotta go. Isn't this just the perfect picture? It really is. All right. So the title of the presentation is The Right Attitude for the Assessment of Pelvic Pain from the Perspective of Your Patients. So my name is Jill Osborne. I'm the founder of the IC Network, the U.S. National IC Support Group leader with live streams, support group meetings weekly on YouTube and Facebook. I'm the longest serving IC support group leader in the world at 30 years and counting. And my website, the IC Network, has been rated the best on the web for accuracy and credibility in 2 peer-reviewed studies. I've been a pelvic pain patient since the age of 14 after breaking my tailbone. I've had a typical progression of symptoms beginning with frequency urgency, then urethral stricture, then severe vulvodynia, severe IBS, migraines, and eventually severe bladder pain. My phenotypes are myofascial pelvic pain, pelvic floor, and central sensitization. My treatments are physical therapy and mind-body medicine. And I am currently pain-free, thank God, because it's rough, as you know. Now, here's the single most important phone call I got just after I started the IC Network. I answered the phone. IC Network, this is Jill. Can I help you? And it was a man who was sobbing. He couldn't talk. He was crying so hard. I just kind of whispered to him. We did some deep breaths. Took him a couple minutes to collect himself. And what he said absolutely stunned me. He said, I am the chief of one of the biggest trauma units on the East Coast. I have IC and pelvic pain. I live with pain every day, and I have told no one. And I asked him why. And he said, because they laugh at patients and believe it's a mental illness. The minute I tell them, I will lose all of my professional credibility that I've worked so hard to build. But I can't do this anymore. I need help. So, what do we patients want from you, our doctor? We want a kind detective who will help us figure out why we are in pain and what we can do about it. We want someone who listens, someone who believes we are struggling. We want someone who will help us when we are scared and in pain. And we want someone who will teach us how to get better. Whoops, went the wrong way. Oh, wait. But just as we see In support groups, there are two very distinct populations of patients also in their clinic: first timers versus grizzled veterans. And they each have very distinct needs. So, for the first timer, this is their first appointment to discuss pelvic pain. They have a recent onset of symptoms. They have little education other than the internet or social networking, God forbid. They are embarrassed to talk about intimate problems. They may be worried about cancer and other life threatening issues. I've shared many a time that I absolutely believe that I had terminal cancer the first year I had bladder pain. So much so that I demanded exploratory surgery, which they did. And I never had cancer. But this level of pain will trigger those thoughts. These patients are desperate for a diagnosis, but they are usually hopeful and they're open to suggestions. In contrast, let's consider the grizzled veteran. You are their second, third, fourth, fifth, sixth, or seventh consultation. These patients have failed multiple therapies. They have intense pain and insomnia. They may be unable to work and in financial distress. I can promise you they have been told it's all in their head. They have very little trust in medicine now. They feel hopeless and they may be at risk. So, how do we approach the newbie? Well, we need an upbeat, encouraging, and informative appointment. And while we may lack knowledge, we often have an intuitive sense of what triggered our symptoms. So please ask, is there any event that you associate with the onset of your symptoms? What do you think caused it? Now, please know that we may not know how to describe our pain or where it is. It just hurts down there. So simple questions really help. Like, where do you think the pain is coming from? Is it inside or the outside of your body? Can you touch it with your hands? Does the pain occur before you urinate or after? Does the pain change when you move your body or you sit down or you stand up? Newly diagnosed patients are desperate for educational information and self help tips. This is the perfect time to give patients good educational materials. We have a lot of those on the IC Network website in our free download area and also on facingpelvicpain.com. And of course, your doctor may ask you to do a symptom checklist, or your doctor may use a symptom checklist or an assessment form. This is important because it allows them to collect a lot of information very quickly so that they can actually use that appointment to talk directly with patients more rather than asking about a lot of symptoms and history. So, what are we going to do with these newly diagnosed patients? Well, phenotyping, of course. Why? Because the pelvic and bladder pain is a remarkably heterogeneous, also known as varied patient population. You're not all the same. For some of you, IC begins in childhood, for others, after menopause, for some, while going through chemotherapy, while for others, after they fall on their tailbone. For many, it's associated with estrogen atrophy. For quite a few men and women, it's associated with a fall or trauma to the pelvis, like a broken tailbone. Do not assume that a disease is triggering pain. For most IC patients, it is neuromuscular in origin. And phenotyping helps you identify the most effective treatment modalities, and phenotyping will save you, the doctor, time and the patient's money. So, what are our IC phenotypes? Well, as we know, Dr. Christopher Payne was the first in 2015 to propose 5 distinct patient groups: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, each having their own unique treatments. And this is the system that I've used here on the IC Network and in my coaching sessions for well over 5 years. It's an outstanding system because it helps the patient understand the concept of cause and effect and treatment priorities. So, as an example, I was working with a patient last week whose muscles were so tight, she hadn't had a pelvic examination in 25 years. She was in avoidance. I'm not doing that. I refuse to do that because it hurts so bad. And of course, what she did not understand is the long term toll that those tight pelvic floor muscles were causing. And that it was those tight muscles that were making sex so painful. It was those tight muscles that were making it so difficult for her to empty her bladder and were contributing to constipation. And so this subtyping system helped her understand why she had to consider for the first time in 25 years working with those very, very painfully tight muscles. Now, interestingly, the powers that be, the American Urology Association and the National Institutes of Health, now they're very slow. They want a lot of research supporting any changes like this. But finally, last year, in their guidelines, they support three distinct groups. They combined a couple of Chris Payne's groups. So they have bladder wall driven, but that includes Hunner's lesions and things like estrogen atrophy and infection. I disagree with that. They believe that the pelvic floor group is a distinct group and that the widespread pain group is a distinct group. And then, of course, earlier this year, Dr. Curtis Nickel, the top IC researcher up in Canada, proposed 9 subtypes. And that's what Chris Payne was hoping would happen. He believed that there would be more. And Curtis Nickel took that challenge and said, yeah, I think there's more. Urethral pain, infection mediated, allergenic cystitis, primary storage symptom, and more. So the take home message here is that when we use a phenotype, we can prioritize treatment and focus on the best treatment for a patient's unique case of pelvic pain and bladder pain. But now comes the hard part, approaching the grizzled veteran. And I know grizzled veterans are watching this right now. And this is why I put this in here, because you're my people, because I've been there. So, what does a grizzled veteran need? Well, we need a master detective and an expert in pelvic anatomy. And please assume that we have some knowledge, but it's often quite outdated because they gave up 10 years ago and they haven't read anything recently. And grizzled veterans often believe that we will live with pain for the rest of our lives. But let's just say you're that patient where you did Elmeron for 10, 15 years. You did bladder installations, but the problem is you still flare. You might be feeling a little bit better, but are you symptom free? No, many patients are not. And if our bladder therapies have failed, then is it really our bladder? And I would ask you too, for those of you who have had cystoscopy with hydroextension, and they tell you that you have a normal bladder, and you're going, what? How is that even possible? I'm peeing every 10 minutes. And you're gobsmacked. It's like, what? Well, we have to turn that perspective around. That's great news. You got a healthy bladder? Outstanding. What does that mean? We don't need to do bladder therapies. We have to look outside of the bladder for the underlying cause. Thus, these patients need a deep phenotyping to look for those other causes. And a pelvic floor assessment is critical. And for severe pain patients on bladder fill, in other words, you're in agony as your bladder gets full, we want to make sure that Hunner's lesions are present or not present. If they are present, they need to be treated. The number one cause of very, very severe pain in the typical IC patient is going to be an untreated Hunner's lesion. Now, predictably, many of us struggle with central sensitization, widespread pain, a critical and often rejected therapeutic target, rejected by the patient. And I'm hoping that I can turn you around. So, how do we know if you have central sensitization? Well, ask the patient, do you have very sensitive skin? Can you wear wool? Do you have a very sensitive sense of smell? Do smells make you kind of ill sometimes? Do you struggle with other pain conditions like IBS, vulvodynia, fibromyalgia, TMJ, etc.? And a telltale sign of central sensitization is anxiety. Do you struggle with anxiety, catastrophic thinking? So, what do CSS patients need? We need nerve calming techniques. You can spend years calming that bladder down, but until you calm that central nervous system down, other parts of your body are going to fire off. So we have to reinforce the concept of injured nerves and muscles causing neurosensitization. We also call this a central nervous system maladaptation. And the International Pelvic Pain Society has excellent resources on this. I recommend their annual meetings and courses to professionals. And for patients, they've got some really good patient education materials out there. And they're doing their first patient event in a week or two. And I will tell you, I've gotten some of my best information from International Pelvic Pain Society meetings. Now, for the doctor that has now identified signs of central sensitization, we have to probe gently about trauma, physical and emotional abuse, but with some very basic trauma-informed care principles. You'd be very surprised by the number of patients with tailbone injuries, falls downstairs, or childhood abuse. Doctors must explain that calming the central nervous system and training the brain away from fight or flight will help to reduce pain throughout the body. And how do we get that brain out of fight or flight? Well, with mind body medicine. Also, anxiety management is essential to triggering fight or flight, to avoid triggering fight or flight throughout the day. And the IC Network has some excellent mental health resources. So, if the usual IC therapies provide no improvement in symptoms, then the clinician should revisit the diagnosis and consider whether an unidentified disorder may be present that is producing symptoms. This consideration may require additional diagnostic workup or referral to appropriate specialists. So, what does that mean? If your bladder therapies aren't working, stop what you're doing, take a step back, revisit the diagnosis. Let's see, did we miss something? And a quote from my favorite author: one size does not fit all when treating chronic pelvic pain. The therapeutic approach must be tailored to the patient's unique needs. Therefore, I regard every case as a mystery to be solved and have made it my mission to help patients um, others have labeled as difficult and untreatable. And of course, that's by Dr. Jerome Weiss, the author of Breaking Through Pelvic Pain. Now, here are my three favorite references. For the veteran patient for which the mystery has not yet been solved about the cause of their pain, Facing Pelvic Pain is the book to get because it covers everything. It covers gynecological causes, covers male reproductive prostate causes, it covers orthopedic issues, it covers infectious issues, it covers neurological issues. Super easy to read. Short chapters written by some of the best out there. I'm actually one of the co-authors of this book. This is the book I wish that I had had 30 years ago because it would have helped me, 40 years ago, would have helped me understand all the struggles that I was having, and certainly that I was not alone. Now, for patients where we have a very clear pelvic floor pathology, tight dysfunctional muscles, this book, Breaking Through Chronic Pelvic Pain, is absolutely my favorite book. It is a masterclass in pelvic anatomy. And for you, the patient, you got to know what they're touching. When you go to physical therapy for the first time, I want you to be able to visualize what they're touching. And then, of course, for newly diagnosed patients, IC 101, it's not just a bladder disease. And this is my last page. Somebody keeps calling. I got to go answer that phone. I'll be right back. Oh, that was so cute. That, you know who that was? That was my very, very elderly cousin. My dad was 6 kids. He was the youngest. This was the daughter of one of the oldest. So she's much, much older than me. And um, she, during the fires, she couldn't find us, and she thought we had died in fires a couple years ago. And so if we don't answer the phone, she panics and she calls over and over again. She would have called the sheriff or the police department literally in 2 minutes if I hadn't answered that phone. So thank God I answered that phone. Oh my God. What a day. What a day. Guys, I've been up since 5 this morning. I have been working straight for since last Monday. So I might be a little punch drunk right now. All right, let me fix this here for a moment and give you my face back. Okay. So that's the presentation that I did, kicking off this year-long here, hold on a sec. Where is my Chrome? Okay. So kicking off this year-long series of meetings into pelvic pain. So I think it's absolutely fabulous that we were given such a significant role in that meeting. And I will be at their future meetings too, and they really appreciated my input. Now, the cool thing about this meeting is it wasn't just urologists, it was gynecologists, it was orthopedics, it was neurologists. This is truly an international uh, cookie jar, for lack of a better term, a beautiful group of doctors from around the world. One of the doctors who gave an absolutely fascinating presentation was a doctor from Hungary. So I got to see, for example, was very, very interesting because remember, you are an anatomical mystery to be solved, right? And when we think about all the things that can contribute to pelvic pain, there are basic things we have to rule out that they have to rule out. They've got to rule out, for example, um, I saw some very impressive pictures of rectal fissures. I, all the funky things that can happen down there, chlamydia infections, syphilis infections, a urethral caruncle. I don't know if you've ever heard that term caruncle. A urethra caruncle is when it sometimes happens in older women where it's kind of like a urethral prolapse where the urethra kind of starts to slide out of the body. But remember, it's a tube. And so what happens is you get this little flower of urethra at the entrance of the urethra that can be very, very painful to touch. Got to see a lot of pictures of bad hips and SI joints and things that compromise nerves, things that compromised. A fascinating picture was actually a CAT scan, a woman who had really significant pelvic pain. And when they did a CAT scan, the first thing that you saw was that one kidney was nice little firm kidney. And the other one was really big and kind of diffuse. There's a lot of fluid around it. It was weeping liquid. And you'll go down the x-ray and look at the ureter, and you can see that there's actually a kidney stone blocking the ureter Thus, all that urine from that kidney is going right back up into that kidney, causing that kidney to swell and all this sort of stuff. So there's a very, very rigorous diagnostic workup that your doctors want to do because they want to save your life. We saw pictures of herpes, and I've worked with patients with herpes. We know that IC will flare with herpes infections. Um, Pictures of HPV-driven cancer. I'll never forget a woman who called me a couple years ago. She was 32, and human papillomavirus is a virus with many different families or species. No, it's one species, but it's many different groups in that. And some of those are absolutely known to cause cancer. And so human papillomavirus, if you're unlucky to have one of these bad strains, can cause rectal cancer. It can cause mouth cancer. If you happen to do oral sex, it can cause um, urethra cancer, vaginal cancer, etc. So anyway, I had this 32-year-old woman who had been diagnosed with urethra cancer from HPV. And they removed her to save her life. They removed her urethra, they removed her bladder, they removed her vagina, they removed her cervix, they removed everything. She was empty, 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 empty on the inside. And they told her 6 weeks later she could go back to work. Are you kidding me? She could barely walk at 6 weeks, and she called me in desperation and asked, "Is that normal?" And I went, "No." You're looking at a year-long recovery for a major, major surgery like that. So we want to prevent that happening for you. That's why that diagnostic workup is so incredibly important. Your ability to contribute to that discussion is also equally important. And some of you, I'm just going to say right now, do not know your body. You've never looked down there. Why? Your body is your body. There's nothing to be ashamed about. You have to know what things look like. Like for me down there, I'm very red. And every time a doctor looks at me, they go, "Whoa, you are red." And I know it's normal. And they're like, "Okay." That kind of freaks doctors out every now and then. So, number one, you have to become familiar with your body. You've got to, and because you're the only one living in your body, you're the only one when you need who knows when you need to urinate. And so you're the captain of your ship here. And yet some of you are very reluctant to learn more. And when you go to a doctor, I want you to know what the urethra is. Some of you don't know what a urethra is. Some of you don't know where that is. It's in front of the vagina in women. I want you to know the difference between a vagina and a vulva. The vagina is on the inside. The vulvas are the lips on the outside. Some of you don't know what a ureter is. And before you go to that first appointment, please come to our website, use the internet, look at some basic anatomy so that you don't look foolish. Because you will look foolish if you literally don't know where your urethra is. That is indeed where your urine comes out of your body. That's the hole. Um, and for those of us whose cases are not as simple, and for those of us who have very clear injury trauma and or muscle issues, you got to take it another step up because we're long past the day of you walking to a doctor's office and saying, "Give me anything, make it go away." We're long past the day of giving patients Elmeron, an antidepressant, and the diet and seeing you in 6 years or 6 months or whatever. We know that does not work for the great majority of patients. So we don't want you to walk in and ask for an antibiotic. We don't want you to walk in and say, "Just give me a pill." We don't want you, as Angel says, anxiety can cause bladder problems. Yeah, listen, if you're in fight or flight, you're going to pee more. But another example, so I was working with another patient recently, very recently, who um, hadn't had a pelvic examination in 25 years because it hurt so bad. And we have to challenge that. Number one, that wasn't safe for her. And number two, if your muscles are so tight that you can't put a speculum in without screaming, then certainly you can't have sex comfortably. She said, no. I said, are you willing to live with it or are you willing to try to fix this? She's like, of course I want to fix this. Well, then we need to have a proper muscle assessment because you have some messed up muscles here, but it'll hurt. Yes, it's going to hurt at first, but don't you want to get better? The fact that it hurts means we're working in the right direction. And we'll have to be extra gentle with you and try to figure out while they're tight, right? So avail yourselves of these fabulous resources that we have. I want you to walk into that doctor's office knowing where your levator ani muscles are. Those are the shallow muscles. Wrap around the urethra, wrap around the vagina, wrap around the rectum. Those are the muscles that get so tight and squeezed that sometimes you can't release your urine. Then there are deeper muscles. And ideally, as you're laying there with your feet in the air, with feet in stirrups, knees in the air, and the doctor is touching you, whether rectally as a man or vaginally as a woman, I want you to be able to visualize what they're touching in your body and what it does. You are a part of this. You don't have the time to be passive anymore. You must be active and engaged and informed. We have great books. A lot of this stuff is completely free on the IC network. No excuses. Please go read it because we just want you. I don't want you to be in pain for 30 years like I was. I told them in the conference this morning, listen, I broke my tailbone at the age of 14. This is my progression of symptoms. I didn't get complete relief until I was like 53 or 55. 40 years of unnecessary suffering, 40 years which robbed me of having a family, 40 years which robbed me of enjoying a vacation and enjoying sex. I don't want you to be me in that respect. We've learned now why I was in pain for so long, and it was never my bladder, even though I was peeing every 5 minutes on my worst days and nights. It was always my muscles and my nerves caused by that original injury when I was 14. So I want you to get better. Okay, you guys, you're saying a lot here, and please don't be offended if I don't answer your question because sometimes I get on a roll, as you know. So let me check these questions here. Carolyn says, been on estradiol vaginal cream for 2 weeks. Now the skin on my body feels itchy. Could it be from the cream? I also got new dryer sheets. Oh no, it's the new dryer sheets, honey. The new dryer sheets. Easy. Did you guys those there's a company that's selling water-free laundry detergent. And you just like it's like a wafer or a sheet of something, you just put it in your washer, and then when water goes on it, it suds up, right? And that makes total sense. Why are we buying water? We have water in our taps. Well, those of us who are not in a war zone, we have water in our taps or in floods or whatever. And I thought, you know what? This is a great thing. This is a great thing that I can do for my family. I got that. I used it. I washed my sheets in it. Oh my God, I itched all night. And Cynthia, you use those, Donna? Girl, oh my God. They were agony for me. And when I went back to Amazon and I looked at the reviews, which is so interesting, is in families, some family members were fine, other family members were in agony. That's crazy. Hi, Danny. Hi, Danny. God, Danny, I'm still happy from our talk. Thank you so much. You were wonderful. So Carolyn, I'm putting my money on those dryer sheets. Sandra says, I haven't been here for a couple of years, so checking it out. I've been stayed pretty stable. I'm thankful I didn't take much Elmeron. I couldn't tolerate it. I'm in my mid 80s. I still have IC. Today I overdid my exercise by walking 5,000 steps. Now just getting into that all over bad feeling. Okay, but honey, you know what triggered it. And that is you stressed your muscles. So probably what's going on is your muscles are tight. So grab a heating pad, put a heating pad on your pelvis, do some gentle stretching. I don't know if you have a muscle relaxant. If you have a muscle relaxant, that might help. And one of the points I reemphasized in our meeting this morning is, why is the pelvic floor patient diet sensitive? Because there are consequences to having tight muscles. When you've got tight muscles, they restrict blood supply. The bladder gets starved of oxygen and nutrition, and the bladder wall starts to break down. That's called ischemia. But for that patient, bladder treatments will never fix it, because bladder treatments don't restore blood supply. Physical therapy restores blood supply. So, Sandra, concept number one here is, if it doesn't improve in the next couple of days, you could go ask for a pelvic floor assessment. Taking a warm shower, just using some heat to relax those muscles might really, really help. Also, Sandra, the other thing you need to be aware of, and girl, I'm so impressed that you're in your mid 80s and walking. I want to be you. I'm walking a lot. I'm trying to walk a lot too. But the other thing that's definitely influencing your health right now is estrogen atrophy, including your bladder and your vulva and your urethra. So the other thing is, if you're starting to feel like your urine's very hot, like as you're urinating, it's burning you. Well, it's not really burning you. What it means is that your skin is getting dry. You know how dry mouth is painful? Well, dry vulva is painful. Dry urethra is painful. So you might want to have a discussion with your doctor about the quality and health of your skin down there, and perhaps using some topical estrogen. Hi, Ruth. Hi, Nancy. Denise loves my pumpkins. Yeah, they have a timer. I got my lights up on my house now. Renee says, is the HPV warts? Is it? I'm not sure. Anybody know? And again, for anybody watching, if you took Elmeron and suffered eye damage, retinal damage, I have a major national newspaper that is trying to put a face to the story of this tragedy. And if you would be interested in speaking with a reporter, a very, listen, this is the best of the best of the best. On this is not a cheap newspaper. These are the upper echelon prize winning. I would never allow that to happen. But anyway, if you could email me, icnetwork@mac.com. I have a reporter that would like to tell your story. And we need some people soon, okay? Aaron says, I get so bloated in my stomach during a flare. Urologist says it's IBS. Gastro says it's IC. I'm thinking probably both. Your opinion. Thank you. Aaron, I did ask Dr. Theoharides this question many years ago, and he said he thought it was inflammation. We call it the IC belly. It's just you wake up with a flat stomach and 3 hours later you look pregnant. What the hell is this? This is why IC patients often need to wear stretchy pants. Having anything tighter around your waist is very, very uncomfortable. And sometimes it's related to food. For me, I will tell you that happened to me a little bit this morning because it was completely off my game. And so what did I have this morning? I had 2 cups with sugar of Dandy Blend, and I had a muffin, and then I had a banana, and there was no protein in there. It was like all carb, and my belly immediately went, woo. This is why I'm wearing a long tunic right now. I find that that's what happens when I eat a lot of carbs. Peggy says, I've been doing pelvic floor therapy for 8 weeks now. My stream is better and not getting up at night as much. Yeah, baby. But the bladder pressure is still there. That's okay. You're making progress. Plus, since I started, I had pain in the vulva on and off and sciatic pain more in the right buttocks. I told my therapist about it and she said to back off on the stretching. Good. You have an appointment on November 20th to see a urogyn. I want to have a cystoscope to see how my bladder is doing. I'm still on Elmron TID. I tried tapering off, but my bladder got worse, so I restarted it. I also started glucosamine and chondroitin. Okay, so Peggy, you know, um, understand that Elmeron has a coating effect. That's why it's helpful. But something like Cystomend and Bladder Builder and Bladder Rest also have a coating effect. Elmeron is synthetic. The bladder isn't made of synthetic materials. Bladder is made of natural materials. And one of the ingredients of the bladder, one of the molecules in the bladder wall is chondroitin. And so many patients over the years have transitioned off of Elmeron and over to something like Cystomend or Bladder Builder or Cystoprotect. So there's lots of things out there for you to try so that you're not risking your eyesight. Peggy says, hold on. Once I slacked off on the stretching exercise, the vulva pain stopped and the sciatic got better. So now I don't know what to do. No, it just means, honey, it just means that you're changing the health of your muscles and you were putting a little bit of stress on your piriformis muscle, which is squeezing your sciatic nerve. That's fine. You're learning a limit, but that doesn't mean you need to stop your physical therapy. You've now learned a limit. You just went a little bit hard on that side. So you got to back off a little bit, but we got to get these muscles healthy. Carolyn says, my face is itchy too. I was crawling. My skin was crawling, hun. It was so bad. It was so bad. Denise says, I have genital urinary syndrome of menopause. My ovaries removed like 9 years ago. I do take estradiol, but sometimes I kind of handle the itch on the outside. I've tried everything. Do you have a remedy? I'm at my wit's end. Yeah, it's V Magic. Denise, have you tried V Magic yet? See? Stomach covering. And it's already down. It's already down to what it was. V Magic. This would be the next thing to try, Denise. Is something like V Magic, which is an organic avocado, olive, and sea buckthorn. Lots and lots of patients use this very successfully. It is about as close to a match of human mucus as possible. It's not sticky, very close to what normal human mucus feels like, and it will protect stuff down there. But also, Denise, the fact that you're itching so much, you have to remember that because you're in estrogen atrophy, your skin can't protect itself. You don't have a nice thick coating of mucus. And so you have to remove any and all chemicals from touching your body. You got to look at your laundry detergent. You cannot use fabric softener. Rinse your underwear twice. There should be no scent to it at all. You have to be very careful with your soap. You cannot douche. You shouldn't be using something like Cottonelle. Cottonelle, they market it as good for cleaning, but Cottonelle actually has a preservative in it that's quite irritating. There's a really good water wipe, though. I have samples of it in my bathroom. So if you see something called water wipes, those are pretty good. But the most important thing that I can suggest to you is this little baby, a Perry bottle. It's under $3 in my store. So the ladies at the Vulvodynia support group meeting I went to when I was like 18 or 19 took me under their wing. My vulvodynia was so bad. And they're the ones who taught me this. Toilet paper will not get all the chemicals off of your skin. Water will. So be consistent. I challenge you to use a Perry bottle every day every time you use the restroom for a good month, let's just rinse that skin off, remove any and all chemical irritants. This helped me tremendously. So you can get this in the IC Network store under restroom supplies, under $5, $4, something like that. You guys have been talking for hours, so. Okay, so please get one of these. Thank you, Danielle. Oh, girl, you have no idea how good that makes me feel. Caroline says, what can we do for bloating? Not eat more carbs. Wear comfortable clothes. Get out and walk. If you're belching, doing something like Gaviscon, do you feel gas in your stomach? I have very mild gastroparesis, and so I often have just a little bit of gas in my stomach. And sometimes, what's so funny is that it tickles my esophagus, and so I feel like a little, like just a little light on the inside. It's like a little flip flopping, and you're first feeling it and going, "Is that my heart?" It's like, please don't be my heart. And usually within 30 seconds, it's like, oh, I need to belch. It's gas. My go-to is Gaviscon. Gaviscon. I had a IBS specialist recommend it. What makes Gaviscon so good, other than Mylanta and that other stuff, is it puts a foam layer on top of your stomach that keeps the gas underneath it so things don't get so irritated. So anyway, Mary says she takes Beano for starchy foods. That really helps the bloat. Yeah, you got to learn what your gas producing foods are. Like you couldn't pay me to eat cabbage. Oh my God, Brussels sprouts, doom. I haven't had a Brussels sprout in 30 years. I had the worst gas after eating Brussels sprouts. Like clean the house out, Jill. It's going to be a while. Hold on a sec. Can you put here? Hold on. Wait. Linda says, what do I need to expect from a cystoscope? Doctor said it would be in the hospital. Well, Linda, you got to ask what they intend to do. Because remember, they need your opinion they need your permission to do it. So a cystoscope is simply numbing the urethra and sticking a scope in there and looking around. I call it a looky-loo. I've had two in the doctor's office. No big deal. The challenge with a cystoscope is your urethra gets stretched out, and so peeing afterwards is not fun for about a day, but it's an opportunity for the doctor to look. And it's important. If you've been in pain for an extended period of time, let them look. You deserve better than guesses. Sometimes they just really need to look. Maybe you've got a bladder stone. Maybe there's something else going on. Letting them look will only help. But the fact that they're doing it in the hospital kind of implies that they might be doing what we call a hydrodistension with cystoscopy. So what that is you're under anesthesia, and they slowly fill your bladder with some fluid, stretch it out a little tiny bit, drain it out, put some more water in there, and it allows them an opportunity. It gives them the opportunity to look more closely at your bladder wall and maybe do a biopsy. And if they see anything like a Hunner's lesion, they can treat it at that time. And it is very, very important that you ask that doctor who's doing that, if you find a Hunner's lesion, will you be treating it? Because one of the greatest tragedies, in my opinion, are patients who have the cystoscopy, the hydrodistension with cystoscopy. They're told they have Hunner's lesions, and the doctor does crap. Come on, you're in there, do it, treat it. And in fact, that's what our AUA guidelines say, is if you find lesions, treat them. Don't send the patient home with an open Hunner's lesion. They're going to suffer. And some of you have had lesions for years. You and your diet has been impaired. You're living in very high pain because your doctor was freaking lazy. And so it's important to ask, if you find a lesion, do you intend to treat it? And if they say no, I would say, why? Now, sometimes they don't have the equipment. They don't have the equipment to treat it, and that's legitimate. But if they just say, "Oh, we'll just do it another time," you gotta understand the ramifications of that. Because what that means is that another trip to the hospital, another round of anesthesia, another hydrodistension to do it. It is a waste of time. When they find lesions, our guidelines say they should treat lesions correctly. They can inject them with a steroid, they can laser them, they can fulgurate them. We've got other therapies too, and we've got a lot of new research about lesions, but just it's a lost opportunity. Just a lost opportunity. Carolyn says her skin feels like it's crawling. Girl, I can relate. Mary says, how much does a star cost? I think it's like a penny or 1/10 of a penny. Danielle says, can you put V Magic inside of your vagina? I don't think so, honey. Mary says, can you show which detergents are good for IC patients? My favorite is 7th generation free and clear. 7th generation free and clear. And I use 7th, so it's a plant-based. Very, very mild. I've been using it for years. I used to use Ivory Snow, but then they did some sort of weird perfume and scent. We used to do Dreft, but the same thing happened. It was a baby one, a baby detergent. And, you know, the manufacturers are like, well, we've got to change it to attract more customers. And now we have a good product that's now irritating. So 7th generation free and clear laundry detergent, it's liquid, is great. I wish I could get a dry version. I'd rather have the dry than the liquid, but it is what it is. Danielle said, is that bottle like a Bodhi for the front part? I don't understand. I don't understand. Okay. So we have to, I have an exercise for us. Okay, I want you to get a pencil and a piece of paper because we are going to see how sensitive your nerves are. And this is something I learned in our conference today. And I've already taken the test for me, and god damn, my nerves are very, very sensitive. So, excuse my swearing. It's been a long day. I apologize. Okay. So I'm going to give you questions, and I want you to write down. So and each question is going to have a score, and we're going to total it at the end. Okay. So this is going to help us determine to what degree we really have to work on your central nervous system. So if you have a pencil and a piece of paper, or you're on a computer, open up a note. Never is a 0. No, I'm sorry. Never is a 1. Rarely is a 2. Sometimes is a 3. Often is a 4. And always is a 5. So I want you to write that down. A 1 is when you answer never. A 2 is where you answer rarely. A 3 is where you answer sometimes. A 4 is where you answer often. And a 5 is if you answer always. So you can either write down the score or you can write down the word. Okay. So Get ready. This is so cool. Number one, your first question. I feel tired and unrefreshed when I wake from sleeping. Is it a never, rarely, sometimes, often, or always? So the question is, I feel tired and unrefreshed when I wake from sleeping. Okay. Question number two. My muscles feel stiff and achy. My muscles feel stiff and achy. Never, rarely, sometimes, often, or always. That's a often for me. Number three, I have anxiety attacks. If you have anxiety attacks, never, rarely, sometimes, often, or always. Okay. Number four, I grind or clench my teeth. Are you a clencher? Never, rarely, sometimes, often, or always. Ooh, that's a often for me. Number five, I have problems with diarrhea or constipation. And again, Danielle, you're supposed to be writing them down. Don't put them in chat. Okay. Do you have problems with diarrhea or constipation? Never, rarely, sometimes, often, or always. Number six, I need help performing my daily activities. Is that never, rarely, sometimes, often, or always? That's a never for me. Number seven, I am sensitive to bright lights. That's a always for me. I am sensitive to bright lights. I can remember as a kid, back before we had computers, I would lay on the couch in my family room, and the light was right at the point where it was shining in my eye, and I complained about it for years. Ugh. Okay, number eight. I get tired very easily when I'm physically active. That's a never for me. Okay. Number nine, I feel pain all over my body. Oh, never, rarely, sometimes, often, or always. I'm going to say sometime. Number 10, I have headaches. I'm going to say for me, sometimes. Okay, so remember your answers are never, rarely, sometimes, often, or answer, or always. Number 11, I feel discomfort in my bladder or burning when I urinate. That's a rarely for me. I feel discomfort in my bladder when I urinate. Number 12, I do not sleep well. Gosh, how would I answer that? I'm going to say sometimes. Number 13, I have difficulty concentrating. Never, rarely, sometimes, often, or always. It's a rarely for me. Number 14, you're going to like this one. I have skin problems such as dryness, itchiness, or rashes. Uh, that's an always for me. Number 15, stress makes my physical symptoms worse. Does stress make you worse? Never, rarely, sometimes, often, or always. That's a sometimes for me. Used to be always. Number 6, I feel sad or depressed. Never, rarely, sometimes, often. Oh, yeah, I can't answer that question because I'm grieving. So, of course, I'm sad. I'm going to answer that sometimes. 17, I have low energy. Never, rarely, sometimes, often, always. That's a rarely for me. Number 18, I have muscle tension in my neck and shoulders. Oh, holy hell. Always. Always. Number 19, I have pain in my jaw. Never, rarely, sometimes, often, always. That is an often. Number 20, you're going to like this one. Certain smells, such as perfumes, make me feel dizzy and nauseated. Always. For me. Number 21, I have to urinate frequently. Never, rarely, sometimes, often, always. Rarely now for me. I'm good. Okay. I have to urinate frequently. Okay. Never, rarely, sometimes, often, always. Okay. Number 22, my legs feel uncomfortable and restless when I'm trying to go to sleep at night. You have restless legs? Rarely for me. Number 23, I have difficulty remembering things. Never, rarely, sometimes, often, always. Well, come on, I'm 63. What the heck do you think's happening? Uh, Sometimes. 24, almost done. I suffered trauma as a child. Never, rarely, sometimes, often, always. That's an often for me. And number 25, I have pain in my pelvic area. Never, rarely, sometimes, often, always. Oh, it's rarely for me now. But would the SI joint count as part of the pelvic area? Yeah, Mary, I am. I mean, physical therapy has just wiped out almost all of my symptoms. So I'm going to say rarely. Okay, so you now have 25 answers. Now I need you to count it up. So remember, a never is a 1, a rarely is a 2, a sometimes is a 3, an often is a 4, and always is a 5. So now I want you to count it up, okay? So let's see, I'm going to count mine up. 5, 7, 11, 13, 26, 28, 36, 51, 55. Ah. 59, 61, 63, 66. Wow. You know what my score is? 72. And I also took it from when I was at my worst. Here, hold on. Let me add that up too. 6, 9, Okay. So, Angels 128, girl. This is called the Central Sensitization Inventory. This is a ranking system to determine how sensitive your nervous system is. And the doctor who was talking about this in the conference this morning said, you can use this to actually see that when we address the nervous system and we try to calm things down, the patients improve. And you can see that in their scores. And so this is a really good way to help you understand to what degree your nervous system is involved. So, for example, I took it during the course based upon me on my worst day. And my score was 85. And then as we did it again, I took it again, and my score is 72. And that is a substantial improvement. That proves that I have been no, it proves number one, I'm absolutely a central sensitization patient, but it also proves that I've been able to structurally calm my nerves down. Mary says, is burning and frequency pressure part of CSS? It can be, yes. That's why one of the questions related to urination. What was that question? I feel discomfort in my bladder and or burning when I urinate. And you notice that it probed about I suffered trauma as a child because we know that physical trauma or abuse of trauma, emotional abuse in childhood will in fact begin this cascade of injuring that central nervous system and leaving that patient in constant fight or flight. That's what the anxiety is coming from. That's your body trying to guard you. When it's, hey, you want to go out to the movies? No. I have to get up and use the bathroom. You want to go to a restaurant? No. You want to go take a drive? No. There won't be a bathroom. You want to? No. I wanted to know, why was I the no woman? Why did my brain do that? Because I wanted to do all those things. But my immediate reaction to every invitation for decades was no. Why? Because that was my brain, that was my central nervous system guarding. It was guarding me. It was saying, don't go anywhere. Your life is at stake. Stay home. You're safer at home. And our challenge here is that childhood abuse is long gone, but the brain remembers everything. And so that guarding today is often a reflection of something that happened in childhood. And so what we have to do as adults today is to prove to our brain we don't need to be in fight or flight anymore. Yes, you were in fight or flight for 20 years if you were dealing with an abusive parent or an abusive partner. But if you're safe now, you're safe now. And what we have to do is we've got to turn that fight or flight off, because that amps everything up. That's what's driving the widespread pain. That's what's driving the anxiety. We got to calm all that back. We got to calm all that down. The central nervous system is the driver of the related pain conditions, the IC, the IBS, the vulvodynia, the TMJ, the sensitive skin. My jaw hurts right now. Of course, I've been talking a lot today. That's what I'm struggling with. My TMJ is just out of control. My stress level, it has been so high the last couple of years. And I don't feel my stress in my bladder anymore. I feel my stress right here on this side. It clenches down. My neck is super tight on the right side. It was so tight last night because I worked all day yesterday on that presentation. So this side is really tight, and it's forcing this side to stretch to compensate. It's supposed to be equal, but as this side gets tighter, it forces this side to stretch. And so now my jaw dislocates on this side. All right. Mary says, I think COVID made me 100 times anxiety worse. Yeah. Yeah. I mean, listen, no matter what anybody says, and by the way, I will tell you, I had my COVID vaccine very proudly Wednesday afternoon. Who did I have? I had a very, very good friend went, you believe in that? And I went, hell yeah, I believe in that. Absolutely, I believe in that. Because the new data that is showing us the tremendous damage that COVID does throughout the body. COVID is not a respiratory vaccine. It does not just infect the lungs. It's the first major virus that attacks blood vessels. It reproduces in blood vessels. That's why it's causing clots. I was just reading this morning about somebody who'd had COVID 3 times, a young woman, like 29, no previous risk factor, died of a blood clot because she was just constantly exposed to COVID. So I am very, very invested in not letting politics stop me from the science. Mary says I'm still masking. Yeah. Sue getting vaccine on Wednesday. And Sue says, I usually feel unwell. I did too this time. I wasn't bad. I had it like at noon, and all afternoon I was good. Oh, I'll come back to that, Lori. Give me a moment. I'm just letting everybody do their scores, and then I'll read out the rankings, okay? So you guys keep adding up your scores. Hopefully you have them. So I was good that afternoon. I was shocked. Even my shoulder didn't hurt. But then I woke up at 1:30 in the morning with the chills. I was so cold. I was just shaking. My jaw was just flapping because it's so unstable. And I had chills for about 24 hours off and on. And then Friday was okay, and I walked that day. I didn't do a big walk because by that time my arm was throbbing. But yesterday I did not feel energetic at all. Like my body was saying no, 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 no. Now this morning I feel a lot more energetic. Sue says my 25-year-old daughter felt a little unwell for a couple of days, but I wish the vaccine was out before I got COVID, long COVID. Yeah, exactly, honey. Exactly. You got to preach your story, hon. Your story is so important to share. So important to share because ultimately millions of people have long COVID now because of idiots who politicize wearing a mask. Okay, let's go back to the scoring. Let's go back to the scoring here. Okay, so you got your score. You want to know what it means. If you have a 0 to 29, it is subclinical. It is not a problem. Do not even worry about it. You got normal nerves. If your score is 30 to 39, it's mild. If your score is 40 to 49, it is moderate. If your score is 50 to 59, it is severe. And if your score is 60 to 100, it is extreme. So I'm still in the extreme. I'm not surprised. I'm not surprised at all. And so, as the patient, what this reminds me is that for me to be healthy, I have to work every day to calm everything down. Everything down. I keep my home free of chemicals. I don't let any toxins in my house that stink. I know that's going to bug me. I work a lot with my stress levels. I try to keep my stress level I mean, I'm working every day on that. I feel myself sometimes getting amped up. I go out, I do my deep breathing, I do my mind body medicine. I do I Spy every day with at least one person on the phone when I'm coaching. I do my anxiety management, my stop sign, deep breath, minimize the thought when I have a negative thought. I am frustrated that living through COVID brought back negative thoughts and fear. Because I hadn't lived with that negative mind chatter for quite a while. And then between the fires and running for our lives from fires and COVID, my catastrophic thoughts came back. And about a year ago, they were real, I had to do my deep breathing and I had to do my stop sign deep breath, but I knew what that was. I knew that that was really remembered fear and that I had to calm my nervous system down. And now, instead of having 20 negative thoughts a day, I might have one. And it's almost always about a natural disaster. What if there's an earthquake? Could the big one happen right now? Or what if there's a fire? That's what my brain does. I'm not worried for me. I just think about a big event. And of course, the war and all the other stuff that's going on right now. Lots of people are in terrible, terrible stress. And my heart breaks for the innocents, and I'm so furious ab- about the people who don't live in those countries who are puppet masters, you know? Anyway, I'm not going to get into politics right now. Sue says, I don't know what you're talking about. I have to go back and listen to it. You're talking about the nervous system. What long-term chronic pain didn't do, I'm sure COVID finished off. I'll have to go back and listen. It's not that it finished it off, honey. It's that you've been injured. You have two really significant injuries. You have your significant injury from that bad fall that you had years ago that messed up your pelvis. And the COVID triggered an injury too. Renee says, I'm in extreme since my mom died September 4th. I'm on all meds. Honey, girl, I feel it. I feel it. I have Xanax. I didn't use it. I just let myself cry a lot. And I talked a lot. If medications are working for you, girl, do it. I'm not saying I won't use meds in the future because grief is a beast. It's just a beast. It's a roller coaster none of us ever got on willingly. Denise says, Botox helped me tremendously with TMJ, same symptoms as you. My TMJ specialist didn't mention Botox. I had whiplash and I've got this giant trigger point. It's like as big as an almond. It's right there. And I've had it for when was I in that accident? I got rear-ended. Oh, I was 22. I've had this trigger point in my neck for 40 years. And I think this would be a good target for Botox. Mary wants to know where these questions are listed. If you just Google Central Sensitization Inventory, but I'm going to do a blog on it and I'll have one on our website to download because this is going to be a fabulous new tool that we're going to use to prove to the patients we talk with why it's important that you do these mind body medicine techniques because we got to calm that freaking nervous system down. We just do. Donna says, yes, indeed, grief can be very debilitating. Donna, how are you doing, honey? How are you doing with it? Okay, so Angela has a high score. Lori has a high score. Donna's at 75, so you're extreme. Jesse is 81. Jessica's 81. And you guys here on Facebook, you haven't mentioned your score. Did I miss scores? You haven't posted some of your scores. It's very you know, normally patients who have central sensitization already compensate for it. They don't know what it is. They just know that bad smells hurt, so they don't let the bad smells in their home. And sometimes it's just really comforting to have a name because you're probably already doing the right things. You're not bringing in this Febreze, scented candles, not using certain rug cleaners. You're using free and clear everything. Odds are, I find that people who are sensitive are much more comfortable in a country, in a suburban area rather than in the city. When I was growing up, everybody said to be successful, you need to work in San Francisco. I started working in San Francisco. It's a beast of a commute, 80 miles each way, 3 hours a day. The work was easy, but my body hated it. Too many sounds, too many smells. I couldn't relax. I couldn't find my center doing that long commute in an urban center. I'm not comfortable there. I'm better in a quieter environment. I'm better working with a few number of people rather than in a big noisy office. And I think one of the other questions is really good to think about, especially if you have young people who are dealing with this, is when you're looking for a career and a job, it's not just about finding a job and career that stimulates you intellectually and is fulfilling. That job also has to match your body. It's about, where are you comfortable? Are you comfortable in a small office? Are you comfortable in a big office? And I think when you're in your 20s and you're trying to figure out who you are and what you're supposed to do, and you listen to other people telling you what you should do, it gets very hard, because in the end, it's about finding what feels good to you. And nobody can tell you what feels good. Only you can tell you what feels good. That's why you got to try lots of different things. There's no shame in trying lots of different jobs. I just say, think big, man. Think big. What do you love to do? Do you love movies? Go in, call a movie studio. See if you can work in the cafeteria and meet some actors. Who knows? That might be the start of you then starting to work for a production company. What do you have to lose? Be pretty cool to work in a cafeteria in a movie studio for 6 months. That'd be fascinating. Imagine meeting Harrison Ford or one of the young hunks right now. That'd be cool. So think big. You get to come first. I was listening to Joel Osteen, and I listen to him every now and then. And I swear every time I turn him on, there's something important for me to listen to. And he was talking specifically about, you shouldn't have to sacrifice your happiness to compensate, to help somebody else who's dysfunctional. If they're not willing to change, um, they're not willing to try to improve. Does that mean that you have to sacrifice your life and suffer alongside them? There were some very, very good lessons in there. Donna says, I have my good days and not so good days. Overall, I think I'm doing better each day. Sometimes it catches me off guard. Yeah, every now and then I just burst into tears. Very random. When it catches me off guard, I let go and feel so much better. Yeah, definitely. It feels good. Pauline says she forgot question 23. Sorry, Paula. Hold on. Question 23 is, I have difficulty remembering things. I have difficulty remembering things. So I will, you know what? I can just get you a link now to this. Hold on. But I'm going to do a blog on this week too. Okay. All right. Let me see if I can find this for you. There's another half of this. The test that we didn't do, but let's see. Is that going to be a good link? Yeah. Yeah, this is the link that I printed out and used. All right. So, Mary, here you go. It's an Donna says thank you for the test. Isn't that interesting? And again, the presenter said, what makes this all the more valuable is that you can actually see improvement with it. You can measure improvement with it. And I really like that. Yes, I will. I should already have it open since I printed out on this computer. Hold on. But again, I'm going to do a blog on it with all the links. Here it is. All right. So for those of you on YouTube, for the people on YouTube, you're on my main work computer, my old computer. I dread the day it dies. And for my Facebook people, you guys are on my newer computer, but I have an even newer computer right there, which is my backup for when my old computer died. Because you got to plan for these things because they happen. All right. So as you know, um, I will stay on as long as I can if you have questions. Once you don't have questions, then we can gracefully end this and prepare for next week. I've been up very, very early since 5 a.m. this morning. So I'm not opposed to ending a little early. We've been on for an hour now, but hit me with your questions. Anybody have any questions? Questions. Did I just overwhelm you? I might have. Donna says, get some rest, Jill. Yeah, I'm going to definitely have to calm down. I'm a little wired right now. It's so weird that you can be wired without caffeine. I mean, I just kind of got wired because, my presentation went well. And I was really happy about that. I was a little scared, to be honest. You're welcome, Renee. She says, thank you for everything. All right. Anything. Well, all right, guys. It's a beautiful fall Sunday here. I say, let's go outside and breathe some fresh air. That's what I'm going to do. So we're going to call it here. I intend to be back next Sunday. Wait a second. Hold on. I might have. Oh, I got to look at something real quick. Oh, good. Okay. Um, I have a second birthday on the Saturday. Okay. All right, guys. Sorry for the short meeting, but it was a very powerful meeting. But it's been a long day for me, and you guys are kind of done with your questions. Uh, the Weak Realtor says, "Are you available for like a 15-minute phone consultation sometime?" Absolutely. I do coaching all the time. If anybody wants to go into Zoom, I'm happy to go into Zoom. If anybody wants to talk one on one or two on one now, if you want me to set up a Zoom, we can do that right now. Sue says, How can I get in touch with you?" Through our website, icnetwork.org. And our phone number is 800-928-7496. I answer the corporate line and the patient education line. You're always welcome to call. It's first come, first serve. Always happy to talk with the people. Wig says, "How do we find it?" It's right on the poster behind me. icnetwork.org. Oh, you're at work now? Okay. 800-928-7496. The way my office works is I usually don't get to the phones until about noon Pacific because I have things like we're finishing up writing our fall magazine right now. So I got to use the mornings to actually kind of do physical work that I've got to do. Um, and then in the afternoon, it's first come, first serve based upon phone calls. And patients who request coaching and pay for coaching always get first priority. But I never do not call people back. If you can't afford it, that's fine. Don't worry about it. Um, Please know that I call back often later because I'm in California. So I'm still working at 5 or 6. So if you're on the East Coast, I may call you back at 8 o'clock at night. So be prepared for a slight. I wouldn't call after 9, but I would call after 8, potentially. So if you just want to chat, happy to see if I can help. Um, if you want to do a deep dive into your case, you want to talk for half an hour or an hour, a coaching is the best way to make sure that we've got the time for you. But I never turn anybody away. I don't ask your politics. I don't ask your religion. I don't ask your nation. If you're an IC patient in pain, I'm here for you. And I just want to try to help because I know what it's like to suffer. And I don't want you to suffer. Peggy says, "I would like to have you coach for an hour." It's $50 for 30 minutes and $100 for an hour. But again, guys, 95% it's free. And I've been known to spend 2 hours for free with people who are in crisis. Do not worry about it. It would be great if you could support, even just become a member. We got bills we got to pay, but I don't turn anybody away. Don't worry about that if you can't afford it. It's okay. My grandma Betty taught me growing up, you got to earn your angel wings. You have to earn your angel wings. And that's what I'm doing. That's what I've been doing for a long time. And she's quite proud of me. I'm sure. I'm sure. Thank you. Yeah. Well, I didn't wash my hair before the conference, so I washed it afterwards. And it was pretty manky. It feels better. So Renee says, "Is my membership up? I need to rejoin." Oh, I can look for you right now. Hold on. Let me just make sure here. You can only see my face. Nobody's seeing my desktop. So nobody can look at what I'm doing when I log into my system. You're not going to see passwords. Except I have to do it on this computer. All right, hold on. All right, Renee Anderson. You are active, honey. It renews on December 22nd. You are good. So our members get our magazine, The Icy Optimist, and they get other things from us too. They get some of our books downloadable. They get all of our depending upon the membership you get, a lot of past magazines. So you can read a lot of previous issues. Got a new master class that I'm working on that our members will have first priority with, and so forth. So Renee says she loves a magazine. Sue says, "How do you find the stars?" I don't know, honey. Facebook is weird. Facebook is one way of supporting, but the stars, as generous as you are, I might get $5 a month from Facebook stars. I'm just and not I don't resent it. I appreciate every penny. Okay, but becoming a member of the IC network for $25 a year is really helpful. Or and giving you something really good, which is a really great magazine dedicated to IC. Wig says, "We go to the IC network to join." Yes. If you go to the IC network, there's two ways of doing it. icnetwork.org. If you go to, um, let's see, you can do it a couple of ways. You can go to our news and blogs page and click on IC Optimist Magazine, and they have the memberships right there. Or you can click on the store and go to IC Optimist Magazine in the store also. Except that's individual. Wait, where's my membership link? Wait a second. What did I do here? I forgot to put it in that pull down menu. Just click on the store link itself. And then at the top of the store, you'll see a link that says memberships. Sue says, "Am I still a member?" Let me look. No, Sue, I don't see you unless it's under another name. Nope. Renee says, "Can you send a check?" Yes, you can send a check. You just get the mailing address off of the bottom of on the contact us. We took off the pay by check command um, in our checkout process because it was so rarely used, maybe once a year. And somebody got very confused and used it, and then they yelled at us because they didn't get their product. And we're like, "Yeah, but you were going to pay by check." And they went, "Oh." So, but we're happy to take a check. Just put a note in there. I want a subscription. Put all your mailing address, your phone number, and all that sort of stuff. We say what you want, and it's either going to be $25, $50, or $100. You get to choose, and then we'll set that up for you. Okay, it's not a problem. Just technology has changed. People keep changing. Mary wants to know of hers. Okay, Mary, hold on. Um, oh, that's right. I've got two Mary Jones. That's right. So the first Mary Jones does not, but you, my dear, Yes, you do, and it renews in February. So you are good, my friend. You are good. So again, give me IC questions. As long as you have questions, I'll stay. I'm happy to take questions for anybody who's coming in. Oh, wow. Suzanne Summers passed away. Remember Suzanne Scott Summers from Three's Company? Wow. Well, we're all getting older, myself included. I want to show you something. So again, I'm just waiting for questions. Once you give me IC questions, I will talk IC. Otherwise, I'm just spewing. Anne says, what was I showing for like $4? It's called a Perry bottle. Perineal wash bottle. Perineal wash bottle. Peggy, I'll try. Hold on. Now tomorrow is my day off, so I might not be, and I might have laryngitis tomorrow. We'll see. Okay, I'm just going to say call for coaching. You guys with me, please be the squeaky wheel. Please be the squeaky wheel. If you don't hear from me and you were thinking you were going to hear from me, call me. I'm not offended. It means I'm distracted. And I'm often distracted by crying patients on the phone. Crying patients get priority. And so people ask to make appointments, and I always qualify it and say, okay, I'm happy to make an appointment, but you got to understand that if I'm working with another patient and it's going along because they're very upset, I'm going to work with that patient first. And, normally when I put that into context like that, they're good with it. Helene on YouTube says, can a bladder wall flare present only as frequency with no bladder pain? Yeah, sure. And really what that, you know what? Hold on. I actually, that's a really good question. Let me think about this for a moment. Can a bladder wall flare only present as frequency with no bladder pain? I would have said yes for sure 10 years ago. Because we know that there is a group of patients whose symptoms are being driven by nerves. So if you have a sensitive bladder wall, either from estrogen atrophy or from UTI or whatever, and you do something which provokes that nerve, yeah, frequency is a sign that the alpha afferent nerve on the bladder wall has been triggered. It's the first symptom that will usually occur. Why? Because the alpha afferent nerve is deliberately easy to be turned on because that's a nerve that tells you when you need to pee. So frequency is often the very, very first symptom of a flare. It's also usually the last symptom to go away because this nerve is just uber, uber sensitive. It's meant to be uber, uber sensitive. So my hesitation in that is thinking about new research we have that proves that tight pelvic floor muscles are often responsible for that neuroinflammation. So it was a research study done by the MAP Research Network, National Institutes of Health, and they were trying to validate the symptoms based upon subtype. And I showed it. I think I even saved it because yeah, I just saw it. What did I do with it? hold on. So in this study, what they found is that patients with a genuine bladder wall defect didn't really have the frequency urgency as much as they just had pain. And it was the pelvic floor group that actually ended up having the frequency urgency. And yeah, man, I just saw this yesterday. Oh, where is this? Because there was a great graph. But these are all articles on Lactobacillus iners. But I had that other article. What did I do with it? Because I remember showing it to you. I showed it to you in a meeting a couple months ago. So I would answer, Helene, I would now answer that question a little bit differently. What I would say is can nerve irritation, well, maybe it's right here. No, that's the viral study. Well, I'll find it at one point in time. I think I would not rule out a pelvic floor flare now, based upon this new data that we have, that frequency can also be caused by tight muscles. And okay, direct proof, because I'm not bladder wall, I am pelvic floor. If you tell me right now, I got to get on a plane tomorrow, I can guarantee what will happen. I will have an IC flare, I will be peeing all night, and I will have an IBS flare. I won't sleep much tonight. I'll be empty tomorrow morning. I will be able to make the trip, but I'm not a happy camper. So what is that flare? Every single time. I haven't traveled since all my symptoms have gone. I mean, I haven't gotten on a plane in 7 or 8 years now. Maybe it's different now because I'm so much better. My nervous system is calm. But before that, traveling was never fun. I hated it. I just wanted to be home. I'd even be in Hawaii and I'd just dream of coming home. Why? Because my brain was guarding, saying, it's dangerous. Come home. You're safe at home. Sue says, would you say that the thing that helped you the most was pelvic physical therapy and working on my nervous system? That's what fixed it. That's what fixed everything. It stopped me from wasting time on bladder treatments. You know, when I had my hysterectomy 6 years ago or 7 years ago, they took pictures of my bladder. I have a baby bladder. I have a beautiful bladder. There's nothing physically wrong with my bladder. I have pictures of it. I've lost those pictures. They're somewhere in my bookcase back here. And at my post-op appointment with my doctor, he showed me the pictures and he goes, Jill, this proves it was never your bladder this entire time. It has always been your muscles, always been your nerves. And so when I invested in the pelvic floor physical therapy, that was huge. And the other thing that was really big for me, because I already had a head start because I was so sick of the anxiety in my 30s, I took a fantastic class and that gave me really good anxiety management skills that really stopped in its tracks fight or flight for me. And once I took that class, I stopped, all my panic attacks stopped. My negative thoughts stopped. I might have had one negative thought every 3 or 4 months. And I knew what to do about it because it's the negative thought after negative thought after negative thought after negative thought, jolt of adrenaline, jolt of adrenaline, jolt of adrenaline, jolt of adrenaline. And that's how the nervous system gets upregulated. You got a lot of stress chemicals going on in there. So our goal here is to get us we have to get off that cycle of negative thinking because having those multiple negative thoughts keeps you scared all the time. It, you calm everything down, then bam, you have a negative thought, and bam, you're right back into fight or flight. And so I was gold until the fires hit. And once you've gone through such major trauma like that multiple times every year, you know, your brain starts to get rewired again. It's like, I used to love the fall. I still love the fall, but now it's like starting in August, July, that's fire season. So we have our fire apps. We listen for the planes, you know? Mary says, if you have Hunner's lesions, you always have IC, right? If you have Hunner's lesions, you have Hunner's lesion disease. In Europe, they call that interstitial cystitis. In America, we call that IC bladder pain syndrome. But really, the best way to think about it is Hunner's lesions. IC really doesn't mean anything. It just means you have bladder pain and they don't know why. But in your case, they do know why. You have Hunner's lesions. And Mary, were you here last week when we talked about the new viral research with Hunner's lesions? Did you watch the meeting? Did you watch the meeting last weekend? Because if you didn't, we've got something very, very new to share. Okay, so let's talk about this for a moment. Let me get a little drink here real quick. So Hunner's lesions, as we know, are a beast to live with, and they're a beast to treat. And they are essentially open wounds in the bladder. They're open, often bleeding wounds in the bladder, various shapes, but generally they're a stellate shape. They can be a line, but they usually has a lot of lines of inflammation going around that original lesion. And of course, one of the mysteries is, well, what the hell causes the lesion in the first place? We would like to know the underlying cause so that we can prevent the cause to try to get your lesion to heal. And you have to remember that medicine is very slow. Medical research is very slow. It's not their fault. It's we're just learning a lot of new things about the human body. So there have been two underlying theories about Hunner's lesions. One was that it represents a nerve that is very, very inflamed because inflamed nerves are release toxic substances which break tissue down. So neuroinflammation. The second theory, but it's not a theory, we have research that's proving it, is that Hunner's lesions are actually the result of a viral infection, virus. And it was the Europeans who 7, 8 years ago or 6 years ago, whatever, they with new next generation DNA urine testing, because one of the big problems is how do we find viruses? With bacteria, we know to grow them. We try to grow them, but not all bacteria eat the food we try to grow them. So we miss a lot of bacteria in a urine culture. Well, how do we grow a virus? That's a whole nother story. That's very, very difficult. So now that we have these new next generation DNA urine tests, they can now look for viral DNA in your urine to see if there's active virus. Now, another thing to really understand is we already know that viruses cause what we call hemorrhagic cystitis. Viral infections, specifically polyoma infections, have long been linked to hemorrhagic cystitis. And generally that occurs, so the polyoma virus is a virus, well, hold tight on that, Mary. The polyomavirus is a virus that's very, very easy to turn on. No, hold on. The polyomavirus, sorry, because I just remembered, oh my God, I've got to do something for somebody. The polyomavirus is a virus we all have, and it is normally silent, but it gets turned on in people who are immune compromised. And so, as an example, they started patients who had AIDS, HIV, often had bladders that were bleeding because of the polyoma virus turning on in their bladder, or patients who have had transplant surgery where they're on immunosuppression drugs. They also were prone to getting, since they're on immune suppression drug, that now then allows the viruses to turn on, and the viruses cause all sorts of issues. So 6, 7 years ago, the Europeans, with this new testing, identified polyoma a couple of times in the urine of patients with lesions. And we're like going, well, this is huge. This is huge, because what does it do is it suggests that perhaps an antiviral treatment could potentially be a new line of therapy for somebody with Hunner's lesion. So the Europeans were slowly but steadily producing these small research studies, and the Americans, our National Institutes of Health, were unusually quiet, and we're here going, guys, what do you think about the viral finding? And for years we waited. Well, 5 years later, they released the results of their viral study. They had the urine of about 250 patients over a long period of time. So they went back and checked urine. What did they find? Polyoma in about 5% of their patients. And they were also the ones who identified fungus in some patients who had a lot of severe bladder wall pain. Okay, so the viral theory is now supported. The problem, of course, is how do we get it tested? And I was contacted. I had a big meeting with Microgen, because Microgen is a company that does the next generation testing for bacteria and fungus. We send people over there if you want to try to have a next generation DNA urine test. Of creating, perhaps, with this new research, something very specific for, I don't want to talk too much about that because I'm trying to be innovative and bold. Okay, anyway. So what happened in September, Mary, is we had a brand new paper, just a stunningly good paper that came from Asia that went into the viral research in depth. And so, and this is the paper. The role of viral infection and the pathogenesis of IC. And I know for you guys on YouTube, but that's all backwards. Okay. So they gave the history. So in 1970, when they first looked, they were using viral cultures. How did they culture viruses back then? They put suspected viruses in rhesus monkey kidney cells, those poor monkeys, or in HeLa cells, I don't even know what those are, or human diploid fibroblasts were inoculated with buffered urine. Okay, anyway, 1970, they didn't find anything. 1985, they didn't find anything. Then Dr. Susan Key at the University of Maryland, she was one of the first to start doing more aggressive testing. She found one virus in one patient. And that was a cytomegalovirus in their urine. That was interesting. And then in 2009, a lot of that European research started happening, 2009. Then in 2014, 11 out of 15 urine samples from Hunner's lesions contained virus. In 2015, another major study found a lot of virus. Using high throughput sequencing technology, polyomavirus were identified in 95% of the urine samples from patients with IC and 0% from the control page. That was in the 2015 study. And so now we're starting to see some research looking specifically for virus, trying to phenotype the virus, and then engaging with antiviral therapy. And the Russians brought something out earlier this year because the other virus that they're finding is Epstein-Barr. So in addition to polyoma, they're now finding a lot of Epstein-Barr virus in the urine of patients with Hunner's lesions. And so in this most recent study, Epstein-Barr bladder infection was present in 87.5% of bladder specimens from Hunner's lesion patients and 17.4% of bladder specimens from non-Hunner's IC patients. Let's see. So it's really about the testing methods they use. So here is the thing that was really fascinating. How do I want to say this? Viruses have to live somewhere in the human body. Because once you have a virus, you have a virus. It goes dormant, and then it gets active. Dormant, gets active. Have you ever had herpes? You ever had canker sores? That's a virus that's going from dormant to active. I have herpes sores right now on the roof of my mouth, which I think came from whatever. Okay. This latest research study was really stunning because they have now found where the Epstein-Barr virus is living and how it's getting into tissue. And it turns out the Epstein-Barr virus is infecting our body's natural painkillers. I mean, our natural fighters, lymphocytes. So they have found the Epstein-Barr virus living in what we call a B cell. So lymphocytes are important. There are fighters. They fight infection. And so it's absolutely stunning to find that the lymphocytes themselves are carrying the virus into tissue. And in patients with Hunner's lesion, Epstein-Barr infection was mostly in the B cells, suggesting that the virus infection is still active and resulting in bladder persistent inflammation. Anyway, there's all this mechanism stuff that's going on. But it's very promising, Mary. It's very promising. So I would ask you, number one, did you ever get mononucleosis? Anybody in your family ever get mono? That's caused by the Epstein-Barr virus. If you have, then it could be that original infection now hitting your bladder. And it would be, we have a lot of research. Again, I'm going to do a big article on it. It'll be on our website. Give me some time to do that. You can take that to your doctor's office and say, I think I'd kind of like to have a viral screen to see if I have any active virus. It's a simple blood test. That would be really interesting because if it shows that Epstein-Barr is active, that then potentially opens up antiviral therapy, or if it's another virus. This is all very new. Our study from research from Russia found when they found Epstein-Barr, they treated it with a very specific antiviral medication. And at the end of that antiviral treatment, there was no virus to be found in the bladder or in the urine. So we know that the concept of an antiviral is sound. The question now is identifying the right virus that could be causing that lesion and finding the right treatment for that virus. And so think about how mind-blowing this is. This is huge. For all those years, people were going, take antibiotics, take antibiotics. Antibiotics don't work against a virus. So we're really getting much clearer. And so if you want to learn more about next generation DNA urine testing, I have a website, bladderhealth.org, but the links are broken. I've got to fix it. That's what I was remembering earlier. Bladderhealth.org has a lot of videos, but if you click the link to Microgen, it won't work. I've got to fix it because they changed it. Or you can just go to microgendx.com, microgendx.com. Make sure you tell them you heard about it from the IC network. Lisa says, what specifically helped you with pelvic floor physical therapy? I do my stretches and breathing exercises, but I'm not sure that physical therapy is pelvic floor is my problem. I did North Carolina, Dr. Evans in November for hydrodistension, cystoscopy, and trigger point injections. I'm praying this helps me. I also thought about Botox, but I'm a little bit concerned about running a risk of having to self-cath. I'm in a constant flare. I hurt on all day. Urination is beyond burning day and night. Excruciating. I'm wondering about pelvic floor and if I should have my wand out every single day. I think my answer to that is number one, you're going to be seeing a great doctor, a master diagnostician. Let's see what he has to say. But what I would be thinking about is looking at the health of your urine stream. If you can start your urine stream right away and there's no hesitation and you got a good, healthy horse pee stream, your pelvic floor is probably good. But if you're stopping and starting, or there's a delay, it takes you time to relax enough to release urine, that says your pelvic floor is part of the problem. And for me, when I use my wand, I'm just looking for tender spots. I go where it hurts and I massage it out. I gently massage it out. Mary says 10 to 15 seconds to void. Mary, you have tight muscles. There's no doubt about that. You took the central sensitization score and you scored 32. That's fantastic. So what that means then is that your nervous system has not gotten more involved in this pain. So that's fantastic. And we don't want it to get more involved, but we want to try to get to the root of this pain so that your nervous system is not being triggered all the time. So remember, I'm very different from you. I entered central sensitization because my broken tailbone was never treated. My muscles were never treated. My muscles were so tight, it was like peeing through a needle. And yet, rather than sending me to physical therapy, they just shoved it open with a wand, which just reinforced the pain and the tension anyway. So, you are an anatomical mystery to be solved. When you go to see Dr. Evans, listen, I want you to take time right now and write down until you see him the weird symptoms. Anything that's happening in your body. You get numbness in a foot. Do you get pain that shoots down a leg? Do you have low back pain? Do you have shoulder pain? Whatever. I want you to write down every weird, freaky symptom you have. Because the devil is in the details here. And it's often that one random symptom that only happens every now and then that actually confirms the diagnosis. So for me, I get a buzzing in my left butt cheek. That tells me I've been sitting too long. It just started about 5 minutes ago. That's my left piriformis muscle going, woo. Thankfully, it doesn't hurt, but it's telling my body, my 63-year-old body, don't push it much farther or you're going to pay. Helene says, I've heard anything new about the UTI vaccine coming to the US. We actually have a new blog on that on our website right now. Go over to icnetwork.org and look at our blog. I just put it up last week. icnetwork.org. And again, if you want to learn more about next generation DNA urine testing, bladderhealth.org. But again, I've got broken links over there. The videos work, the links do not. I just found out last week and I haven't had time to fix it. So you can go to microgendx.com also and tell them that I sent you there. All right. Any other questions? Any other questions? So for those of you who came in late, we started with a presentation I did this morning for an international group of pelvic pain specialists. I gave you the presentation I gave this morning. I've been up since 5. And then we did a fun little test to figure out how sensitive your nervous system is. Something called the Central Sensitization Inventory. And we learned I'm obviously extremely sensitive. I've got the highest scores on their index. But this comes as no surprise, and I'm not worried about it. I'm not worried about it. Mary says, is there a phone number for the new gen people? Yeah, I can get it for you. Hold on. It's just me, genetics happens. I'm a redhead. I already know I'm sensitive, and I know my injury just made me more sensitive. Knowing that is important because it guides me on what I need to do to keep feeling good. And that is to work on calming my nervous system, soothing these sensitive nerves, not provoking them. I want to soothe them. That's why I don't do caffeine, which is like taking a jackhammer to the nerves. And my heart hates caffeine anyway. Renee, I recorded it. I did a special one this morning. I will have it up on YouTube in the next day or 2. Okay. Lisa says it takes me time to get all the urine out. I start and stop. I also have what feels like nerve pain in the right side of my ischiocavernosus area. Well, definitely that's not your bladder. Definitely a muscle and nerve going on with that pain on that right side. Anytime you have pain to the left or right of center, really not your bladder. Anytime you sit down and it hurts, not your bladder. You have pain bending over, it hurts. And if you have pain bending over and it hurts, that's not your bladder. If you have pain walking when you move your body, that's not your bladder. That's muscles and nerves moving and getting tweaked. Okay? All right, guys, I'm going to call it here. It's been 2 hours now. So hopefully, knock on wood, I'm going to do my positive thinking here. I will see you next week. Happy, healthy, and whole. Crossing fingers. Go out and enjoy this beautiful autumn day. All right? Get out every day, get in the sun, get out in the sun while you can. Make sure to laugh every day too, because when you laugh, you're telling your brain you're safe and it will bring you out of fight or flight and it reduces pain. So watch funny things, read funny things too. Okay? All right, guys. I'll talk to you later. Shutting down YouTube first. Bye, guys. See you later.